It looked like you were about to.
You need that song playing in the background as we're walking down. As we're walking up to the podium.
There's one I haven't heard. I haven't heard anybody play that.
We almost died, but we made it.
So, just real quick, I thought this was kind of cool. This was on the old slides.
Oh, yeah.
But when we're talking about was this in your Nearpod or anything? Did he show you this already? Or,
Looks familiar, but I don't think it was.
so if you're comparing the acute renal syndrome, so just nephrotic syndrome, that's like major protein loss, that's where you have the frothy urine. So they're gonna have low albumin in their blood, they're gonna have hyperlipidemia, right? And then that's where they have that major edema. It'll start in the morning with just the periorbital and then progress throughout the day. And then this one has a little mnemonic for the acute post-streptococcal glomerulonephritis, had strep. So that's kind of nice to, I don't know, maybe compare the difference between the two.
Why does strep do all kinds of weird stuff?
I know, strep's terrible.
When I was younger, I used to have strep throat a lot. Like I had tonsillitis.
You're making fun of me for tonsillitis.
And they were about to take them out, and then when they were like they were gonna take them out, I stopped having them.
My kids didn't get it a lot, but my older son, when he was in first grade, he got it 7 times. And every time he got it, he gave it to his little brother. And I'm all, come on, man, what are you doing? Like, what are you putting in your mouth? What are you doing? Stop touching stuff at school. So I had it a couple times. They even had scarlet fever. And I wasn't a nurse at the time, and I didn't think scarlet fever was a thing. I'm like, isn't that like an eradicated disease? Like it was, yeah. I'm like, man, but it was just that 1 year. It was just first grade.
I had it from like up until I was like 8, 9.
Yeah.
Do you have started?
I don't know, maybe.
Yeah, it was just that 1 year. I was like,
And I was
stop
like,
it.
yes, take them out because I'm tired of this. Because you know what? Shot up penicillin, and that hurt.
Ouch. Yeah, that son never ended up getting his taken out. He still has them, but.
My tonsils were like, ooh, never mind.
Never mind, we'll behave.
Yeah.
Is this PowerPoint on Canvas?
No, I don't think so. This was on the old PowerPoint,
Okay.
but I just thought it was cool.
Okay.
You guys want to snap
Extra?
a pic or, because it has that cool mnemonic, and that's the kind of stuff I like.
Okay.
Just like to differentiate between the two. I thought it was cool. I thought I'd share because I found it.
You did post
I like pictures.
Did you put it on Canvas?
No, I did not. We can ask Eric. I don't know why he took it out. I just think it's cool.
You heard me.
We'll ask him to put it on there. Just to differentiate between the two.
Maybe because it won't be on the exam, right?
Well, we talked about both of them. So anything to talk about is fair game, right?
That's.
Wishful thinking.
Did you make the exam professor? Or
I did not, no.
I always ask him if he's not good, so I'm not keeping him.
It's already made, so,
Hopefully he was.
But it's already made except for the 10 questions that we created, right?
yes. which we are, you're right, thank you for bringing that up. We're gonna go over either today or tomorrow, we're gonna go through those.
But that means he said that the more selective apply that we made, the less that would be on the exam. But if it's already made, then ours didn't really affect.
Well, no, cause whatever we put in from your guys' selection, we'll take out
Oh.
other ones. So. You guys will get the benefit of your questions. Cause it'll have to replace, cause he's already given you the, blueprint. So it'll have to replace those questions.
Oh.
Make sure we're like doing like questions.
But what if the team who submitted the question and the correct answer itself wasn't like 100% correct? He's gonna go in and correct it, or he's just not gonna put it in?
Yeah.
Yeah.
We'll make it so it makes sense.
Okay.
We won't give you wrong answers. Not purposefully anyway.
We're trying to trick you.
No, we don't try to trick you. Not nice. I think we try to be very nice.
Now you do.
All right, our last topic for today, before your case study you're gonna do with him, is pediatric emergencies. So what we're gonna talk about today is burns, accidental ingestion, child abuse, but specifically shaken baby, and then drowning, okay? Some of our common pediatric emergencies. So for those of you who have already had, not everybody in here's had their last clinical yet, have you? Some of you have, some of you still have it coming up. So when we talk about pediatric emergencies and specifically arrest, most of the time, if there's a pediatric arrest, it is respiratory. Either one, either a lot of times it's just a matter of they're just so sick that their body just kind of gives out. Children who have cardiac arrest or arrhythmias, most of the time that is either due to if they already have some sort of cardiac defect or cardiac concern, or they've ingested something, okay? Which poisoning and accidental ingestion, unfortunately kids like to put stuff in their mouth, even things that don't taste good. Shock, drowning and near drowning, which is a big thing because we live around water here, right? A lot of people have pools in Arizona. And then traumatic injury, either accidental or not accidental. Excuse me. So a lot of these diagnostic tests are, pediatric emergencies are the things that they would come in for anything. So of course, the first thing we look at, we've been talking about all day, right, is hydration status. What is their hydration status? What are their electrolytes? Because that can cause anomalies and emergencies. Glucose, whether they're diabetic or not. Children who have low glucose can have symptoms, right? CBC and BMP, that's gonna look for what our anemias, our signs of infection, our organ function. That can be critical with things like your near drownings, with your poisonings or accidental ingestions, burns, because they're losing fluid, right? So they're losing a lot of those electrolytes they need. Blood culture, for any kind of signs of bacteria infection that might have got into the bloodstream causing shock. Urinalysis can show us their hydration status. It can show them, it can show us signs of infection, or it can show like metabolic or nutritional, malnutrition, those type of things. ABGs for respiratory function and acid base. And then toxicology, of course, for your ingestion kiddos, right? EKGs are gonna show us any kind of anomaly in the heart rhythm. We might do like an echo to look at any kind of structural abnormalities. And then chest radiography, so that's gonna show us, obviously the lung field is, it's gonna show us, do they have like any kind of infiltrates going on? Is there infection? Is there fluid? In our drowning kiddos. But it also can show things like aspiration, if they've aspirated something, or like foreign object, or proper placement if you have like an ET tube. Make sure that we're in the right spot. So that's where that would be for pediatric emergencies. So this is where your American Heart Association, your chain of survival, when you took your BLS, it talks about the number one thing is EMS activation, right? Call for help and then start CPR. The one thing that's different with kids is prevention is the number one thing, because drowning is preventable, right? Ingestion is preventable. A lot of accidents are preventable. So where prevention is the number one key for survivability for kids, and then that's next thing is going to go to that high quality CPR. Prevention is vital. Okay. When we talk about arresting kids, like I said, more often than not, it's going to be respiratory. We've talked about this during the respiratory. They have smaller airways, right? So they have a shorter trachea, they have a shorter bronchial tree, they have smaller airways. So they're more prone to obstructions if they have a foreign body in there, or if they have any kind of infection or inflammatory process, and those those airways close down a lot easier. They have underdeveloped immune system, so they're at a higher risk for respiratory infections, right? They're also highly contagious little creatures. They like to share things, they like to put stuff in their mouth. So kids do get sick more often. They have, depending on the age of the child, they don't have good motor control yet, right? So things like lack of coordination when you're talking about drowning, even in kids who have been in swim lessons, either one, they just don't have the coordination to do it, or they tire out easy. And then same with choking risks. They put stuff in their mouth and they don't always have the coordination to get out. And then unfortunately we have to consider SIDS when we're talking about infants. Your nursing management in an emergency is going to be for a kid just like it would be for an adult, right? Airway, breathing, circulation, those are your top priority, right? That's your primary. So making sure that the kiddo has a patent airway, a clear airway, that's going to be your top priority. Administering oxygen if need be, depending on their respiratory status. Assisting with ventilations. If they're not breathing properly, if they're not breathing enough, if they have disorganized breathing, you're going to help with ventilation. And then of course, you're going to continue to monitor at all times. One of the things that's a little bit different with kiddos is babies have big heads, right? They're kind of bobbleheads. And they also have really fat necks usually. So sometimes they're not in an ideal position. So we say if they're having respiratory distress, hold them upright, right? Lift the head of the bed. We talked about that with the respiratory kiddo last week. elevating the other bed, sometimes you'll hold them up. But if they're not responsive, they're not gonna be able to hold their head up well, so sometimes you do need to lay them down. And this is where, this is called the sniff position right here. Oops, where's my mouse? Sorry. This right here is called the sniff position. So you wanna position them so that their nose is upright. See how the baby who's just laying here flat compared to when we've got him up in the sniff position, how much more open that airway is. Okay, so that's gonna be a lot easier to make sure that we're getting good, that airway is nice and open. If we are having to assist with the ventilation, that we're getting air in. Same with adults. If you suspect any kind of spinal injury, we don't want to be moving around the head, right? To manipulating their head. So instead of grabbing the head or the neck, you can just grab right here on the jaw and position them. Okay. That's the jaw thrust. So it'll help keep the airway open, but it'll also protect the spine just in case. Sorry. Ugh. Okay, so your primary survey, right, that's your airway, breathing, circulation. That's going to be always your number one priority. Once we have stabilized that patient and we've made it through that primary survey, either one, if it was like a code situation, either we've resuscitated them or whatever was going on with them has been stabilized, that's where we go into our secondary survey, right? So what are we talking about when we talk about disability? What do you guys think? GCS? Mm-hmm. What else? Pupils? Yeah. What else? So your secondary survey is basically your head to toe assessment, okay? So when we talk about disability, we're looking at everything. We're looking at neurostatus, we're checking vitals, we're doing a complete head to toe assessment on that kiddo to see any clues that might contribute, that can tell us what contributed to what happened, and that's including exposure. Take off their clothes, look at their chest. Is there some kind of trauma? Is there any kind of discoloration like bruising? So this is a complete, your secondary, now that they're stable, your secondary survey is your complete assessment, everything on them. You know, feeling if there's no, any kind of spinal injury suspected, you know, feeling the head, feeling for kind of lumps and bumps, palpating that abdomen, looking all over, checking the skin. What did we miss? What happened with this kid? Okay. So that's your secondary after you've stabilized them with your primary. Excuse me. So, like you mentioned, it's going to include our neurological assessment, right? We're going to do GCS. We're going to, if it's an older child and they're awake, we're going to try to orient them. We're going to check their level of awareness. We're going to check their pupils. For an infant, can't really check their level of consciousness as easily, but are they responding to stimuli around them? Are they looking around? Will they follow your finger? Will they look at like a toy? How responsive are they? Are they acting normal? And like I said, head assessment, is there any kind of bumps or any kind of scrapes, any bleeding, anything going on in the head? And then eyes, that's part of your neuro. Are their pupils equal and reactive? Is there any kind of strabismus are they able to track? Respiratory, hopefully they're breathing on their own and they're all good, but what is their respiratory rate? Make sure it's a rate that's within their appropriate for their age limit. Are they tachypnic? Are they brady? Are they on point? How well are they ventilating if they're breathing on their own? Are they shallow breathing? Are they taking in good depth, good rate? Are they having any kind of pauses or any kind of abnormal breathing? Because that could be a sign of some kind of neurological deficit, right? Or respiratory, and we're gonna go down again. And then any kind of increased work of breathing. Are they nasal flaring? Are they using those accessory muscles? So, and then comparing to where they were before with all of this. Is there a change in their breathing pattern? We're obviously going to be checking for oxygen, have them on a monitor. We might do ABGs. And then depending on the cause of the emergency, we might do chest x-rays to see, was there some kind of obstruction, or are there infiltrates? Were they drowning or submersion? Is there fluid in the lungs? So now that they're stable, we kind of look at more of, or things like, are they intubated now? We're gonna check with the, what's it called? The capnography, right? But we can also check and make sure placement, or if they had a chest tube or something placed. Again, so like I said before, if a kiddo's gonna have a cardiac arrest event, it's going to be either they have a cardiac event, defect or something, or there's something that's caused it to happen. Whether they have an electrolyte imbalance, so their potassium's way off, whether they've ingested something that's causing that that rhythm. They don't tend to just go into lethal rhythms just because. Some kind of event has caused that to happen. Same thing like cardiomyopathy, like you're gonna know if a kid has a cardiac history that they have cardiomyopathy. If you know they have some kind of cardiac defect or some kind of cardiac disease, then obviously we're gonna look at a little closer there, right? And this is just for your CPR with kids, no matter what the age is. With children, if you're a one-person CPR, it's always gonna be 30 to 2, 30 compressions to 2 breaths, okay? When you have a second helper there, that's when you're gonna go to 2-person CPR, and then it'll be 15 to 2. So 2 breaths for every 15 seconds. For your infants, you can either use the 2 fingers on the sternum, or you can circle the baby's chest. One thing you wanna be really mindful of is if you're using the circle technique, that you're right at the nipple line and you're only using your thumbs, you're not squeezing the back with your hands as well. So sometimes people will do, you can put your hands on the bed and just use your thumbs that way, so you're not tempted to squeeze the baby. But 30 to 2 or 15 to 2. That's the American Heart Association guideline for resuscitation for children. Okay. So, when we talk about burns, what parts of your body are affected other than just your skin? Your fluid status, why? Yeah, you don't have that protective barrier. What else? What other body systems can be disrupted? Thermoregulation. What else? Your kidneys. Why your kidneys? Yeah, because because of that change in fluid.
You're not getting perfused.
Mm-hmm.
Immune system.
Your immune system, definitely, because now those organisms that are out in the world can get in, right? Because your skin's not protecting you. So burns obviously do more than just affect your skin. So it can change your metabolic rate, which means it can change the metabolism of drugs that you take in, because your kidneys are off kilter, and it can affect your clearance of those. A lot of times your kidneys kind of take a hit and they will kind of freak out and shut down for a minute. So we have to think about that. When we talk about fluid resuscitation for burns, there's a picture coming up, but I think in adults you probably learned about the rule of nines, right?
Yeah.
There's a little bit different one that we have in here, but basically, so this Parkland formula, did you guys talk about that with adults? That's gonna be kind of the same thing. So you're gonna take the body weight in kilograms times 4 mils times the percentage of the total body surface area that was burned, and that's gonna tell you how much volume you're gonna infuse to resuscitate, okay? Half of it's gonna be over the first 8 hours, and then the other half over the next 16 hours. And this is critical because, like she said, you're losing fluid, right? Lactated ringers are the preferred choice. You want to stay away from hypotonic fluids because they can actually worsen electrolyte imbalances. And then we have a whole another set of problems, right? So this is on here for topical, and we're not going to really talk about wound care at all in this, but just I guess know that the like Aquacel and Active Coat, those silver infused dressings are preferred over like ointments. So depending on the severity of the burns, there's going to be a lot of pain management with this, right? So not only pain management, but also you have to think about dressing changes, right? Because they're going to have some kind of dressing change, and that's going to be extremely painful to change if they have dressing changes or any kind of debridement. So while you think about how we're maintaining their pain, there's probably going to need a little bit something extra during those times. Excuse me. So all the different areas that we're going to be thinking about, we're not just worried about their skin, right? And those layers. We have to think about what type of burn this was. We have to worry about airway, because if it was something like a house fire or something like that, is possible that they have inhalation injuries as well, right? So they may have either smoke injuries or burn injuries in the mouth, in the nose, in the upper airway. So we need to be really diligent in assessing their airway, in listening to those lungs, and make sure monitoring their vital signs is going to be a first indicator of shock in our patients, right? So make sure that their vital signs are within normal. We're going to definitely watch them for hypovolemia. We're going to be doing our Parkland and resuscitating them. Calculating your burns. I'll show you that. I think it's on the next one. Fluid management. So once we get through that first 24 hours of resuscitation, we're gonna just do maintenance fluids. And we're gonna actually, instead of using the formula, we're gonna start with the formula for our basic maintenance fluids, but then we're gonna titrate it to try and maintain a specific urine output. We want them to have 1 ml per kilo per hour is gonna be our goal. So we're gonna kind of adjust those fluids accordingly. Again, lots of pain control, especially if there's gonna be any kind of procedures like dressing changes, debridement. And then, like Hayden said, this is a huge infection risk, right? We don't need a secondary infection on top of already damaged skin. So for those wound cares, we're gonna maintain sterile techniques and then monitor for signs of sepsis, which would be to continue, like I said, watch your vital signs. For any kind of signs of shock, we're gonna be monitoring like CBC, looking at white count, that type of thing, right? And then family support. This is gonna be huge. Because this is something that's gonna take a while to get through, right? Depending on the severity of the burns. So this family is gonna need a lot of support. This patient's gonna need a lot of support. They may be expected to have an extended hospital stay, which can be financial burden, emotional burden on the entire family. And then they have to have a realistic expectation of what's gonna be the outcome of this. This kid may have surgeries and skin grafts and different things. This could really be something that's very disruptive to the family. And then just the lifelong ramifications of dealing with like the scarring and the emotional trauma of it. I'm sure they're gonna have some serious PTSD. So anymore, we don't go by the first, second, third degree, that type of thing. So it's just know that superficial burns are the ones that just hit that epidermis, okay? Don't need a lot of care, don't need a lot of involvement. And then you're gonna go to a partial thickness, and that'll involve the epidermis and the dermis, so the top two layers. Full thickness extends through all the skin layers down into that subcutaneous tissue. And then when we get to deep full thickness, that's where it's damaged bone, muscles, tendons, nerves, that kind of thing. That's where it goes all the way through. Which is very sad. And this is just kind of a picture of the different. So this would be like a superficial, partial. You might have some blistering. One thing you want to be really mindful of is if they do have blistering is not to debride those, don't pop them, because that still is a protective barrier, right? And then the deep partial thickness, this has gone through all the skin layers, and then the full thickness, it's gone all the way down. So this is the modified. Let me zoom this. Can I zoom this in, because this is kind of the modified rule of nines. Just kidding. I don't know how to make it. Looks like I should be able to make it bigger, but it doesn't get any bigger. So, because the rule of nines is difficult with children because their body surfaces are so much smaller, there's just less of it, right? So instead, this one goes by age group. So you can see it'll have the age over here and then the body area here.
Do we have to remember all that?
No, you don't have to memorize this chart. Just know how to figure out the body surface area.
Would we have the chart on the exam? Like, you just provide that one?
That's a really good question. Let's put a pin in that one. So, for example, if you have a 4-year-old that has burns to most of their head, their total body surface area is going to be 17%. Don't look at this column. It's kind of weird because it goes by either full thickness or partial thickness, which can be super confusing. Just know that if you have multiple areas, you're going to add them together. So for example, there's a 7-year-old that comes to the emergency department after being burned in a house fire. The patient has partial thickness burns that cover the head, neck, and interior trunk. And then he has full thickness burns to the left upper arm and left forearm. So you're gonna add all that up. So for partial thickness, he's 7, so we're gonna go here, right? So for head, it's gonna be 13. For neck, it's gonna be 2. And then for the interior trunk, it's gonna be 13. And then it says he has full thickness on his left upper and left lower arm. So if you go down here to arms, left upper's 4, left lower's 3. So you're gonna add your partial thickness together, your full thickness together, and then add the whole thing together. Does that make sense? So for example, this kiddo would have his total body surface area would be 35%. Does that make sense? I thought this chart was kind of confusing because I don't know why it has this over here. Because it doesn't really tell you anything different between the two. So just go to your age and find whatever area you're looking at and add it together. So for this kiddo, for example, if you're figuring out his Parkland formula, so you would take that 4 mils times whatever his weight is, times that 35%. Does that make sense?
Yeah.
Birds are kind of confusing.
The chart,
Yeah, the chart, I had to have Eric look at it, because I'm all, this does not make any sense. And this part still doesn't make sense to me. So, this was the example that he had on the previous slide, so he added it to this. So just find your, whatever area you're looking at. I don't know that you're gonna have anything that specific on the exam, but we'll ask him, okay?
on the blueprint it does have, I'm pretty sure it says the
But I think it'll give you, I don't think you'll have like this chart where you have to figure out what it is. Because I think this chart's wonky. But, all right, so let's do this case study for this kiddo. Excuse me. So one of the things it says is burns are one of the most common preventable injuries. Was this preventable? Like what were they doing? 15-year-olds, right? Okay, so what's gonna be our priority assessment? So let's think about our primary survey. ABC, yep. So we're gonna do his airway, breathing, circulation. Is he breathing on his own? We have to think about, does he have any kind of burn injuries internally from,
Look at his airway and nose.
yeah. Skin color, respiratory effort, pulses, all that. Airway, breathing, circulation, inspect the nose, the mouth for evidence of burns. Inspect the skin. I mean, if he's on the, check the chin if it's burned. Skin, we're gonna be looking for erythema, blistering, weeping, or eschar, that's that charred skin. And then what assessment would follow the priority assessment? What would be your next step? Airway, breathing, circulation.
IV access.
IV access. Yeah, that's where we're gonna go into that secondary, right? That disability and exposure. How bad are these burns? And then if he's stable, this is where we start trying to get measurements in depth. How thick is this burn? How deep does it go? So what would be our priority nursing management in the emergency department? Fluids? IV, fluids, right? I'm like, that doesn't make sense because I'm on a different one. Emergency airway management if necessary, putting him on a cardiac monitor, monitoring his pulse ox rate, monitoring his breathing, placing a large bore IV catheter and starting replacement fluids, possibly urinary drainage catheter, cleansing the burns with sterile normal saline, covering the burns with moist sterile coverings, drawing labs, and then preparing child and family for transfer to pediatric burn unit or hospital. If a patient asks you if they're gonna die, what do you say?
Oh,
Try not to.
we're gonna do everything that we can.
No, you say we are doing everything that we
We're doing
can
everything that we can.
to get you better.
And we're gonna keep you updated along the way.
Perfect. That is a perfect answer. I don't ever make promises to patients or to families. You do want to reassure them, but you want to reassure them that you're doing, I don't know the outcomes of this. I don't know the extent of his injuries or what could go wrong. So, we're doing everything we can. We're gonna keep you updated along the way. That's a perfect answer. Be honest. How would you support Alan and his family psychosocially? Resources? So, again, answering their questions open and honestly, talking them through everything that you're gonna be doing, explaining the procedures, explaining what you're gonna do. The family you may wanna call in, like social work or the religious support if they wanna talk to a minister or something. All hospitals have somebody around. Preparing them for transfer, letting them know what to expect. And then it says on here, preparing family for what to expect. It can be a real shock to see your child in an emergency situation. So especially if, you know, they don't look how you expect them to look. I think just that, that initial shock. So my son was just in a really bad car accident on Thursday, and his buddy, he was in his work van, and his friend called me and said, "We're okay, I'm standing here looking at him, we're okay, but can you come get us?" So I thought, okay, I'm gonna be totally fine. It's fine. And then I went to get them, and I saw their work van, and I almost lost it. And then as soon as I saw his friend, who was like all bloody, I completely lost it. And I saw my son talking to the police, and his arm was in like a brace. He's almost 24 years old. And I still had like a total meltdown just to see them in that state. You know, it's kind of scary. So, and they're both fine. But it was just very scary. So if I had come on the situation and they were more injured than that, because they had bumps and bruises, and like I said, he was in a brace, and they had really bad burns from the airbags. But just seeing my 24-year-old son beat up from a car accident, I lost it. So, you know, so things like seeing them like in a severe injury like this can be very hard to hold it together, I imagine. So definitely preparing the family.
Yeah.
This is why we
Okay. I think did I have other thoughts on burns real quick? So, just like I said, because burns are one of the number one most common preventable injuries, what kind of things do you think are important teaching points for family members to prevent burn injuries?
Don't leave the stove on, or after you've cooked, especially glass stove tops, put something over it. Make sure that you can't touch it.
So that won't reach up and touch it. Okay, good. What else?
Keep the handles out of the child's reach.
Yeah, turn them so they can't grab them and knock it over on themselves, right? What else?
Don't play with fire.
Don't play with fire.
Supervise fire 4th of July.
What else?
Matches and flammables locked away.
Keep matches, flammables, candles.
Yeah.
My niece was, what was she, like 6, and they were visiting. I don't know what she was doing, but I had a candle sitting on the dining room table, and she told me she was trying to do a funeral for her little pet thing, or pet shop thing. I don't know what she was doing. Anyway, she lit a napkin on fire and then panicked and dropped it on the dining room table and started a fire on my dining room table. So, keep all candles away from kids. So yeah, open flames, candles, turning the stoves, but also think about things like, do we only get burned by fire? What else burns?
Sunburn.
Chemical burns,
Oh.
sunburns. Yeah, keep chemicals locked up,
It's
straight
just a
away.
white person thing.
So, sunburns. You can get.
It's like, yeah, I get burned by sun all the time.
Yeah, but you can get more than superficial sunburns, right? Anybody
Yeah,
can.
you can get secondaries.
But like hot liquids, like making sure your thermostat is set appropriately. Bath water. Curling irons. Anybody ever done that?
Yeah.
Yeah, that sucks. And then teaching children about fire safety. Not only like don't play with fire, but what to do in case of a fire, right? How to get out of the house safely. They used to, I don't think they do anymore, but like when I was a kid, they taught us weird things, but like stop, drop, and roll was like ingrained into us. And still, when I was in junior high, one of my friends, this was really dumb, but they had one of like those wall ovens, and she had it open, and she was standing by it for warmth, and her shirt caught fire. And even though it was ingrained in us to stop, drop, and roll, she did not. She ran down the hallway. So she had some really significant burns on her back. So
Close before you doze.
if you have fire extinguisher in the home, make sure that you're keeping them current. And then changing batteries in your smoke detectors.
Yes.
That's a really important thing. People don't want to listen to it, so they just take the batteries out. Another thing that people don't always think about are like rechargeable devices. So like those ion batteries for like the electric scooters and stuff, those have been known to cause house fires and garage fires and stuff like that. So yeah. So fire safety. All right. The only abuse that we're really going to talk about is shaken baby syndrome. And for those of you who are going to be doing your TTP at like postpartum, every single parent has to sign something that says, I will not shake my baby, and get sent home with it. Even when they get admitted onto the peds floor, we have handouts that we give them, which is interesting to me because that's not something I ever thought about doing with my kids. But people do. People get frustrated, right? And they don't know how to cope with it. But basically, what is shaken baby? Yeah. Shake them violently, and it causes the brain to kind of to bounce back and forth, right? So it causes an acceleration, deceleration injury, which can lead to retinal hemorrhage, fractures, brain injury, and it's usually permanent brain injury from it. So clinical presentations, this is kind of in less severe cases, I think. The irritability, insolability, obviously they've got a wicked headache, right? Vomiting and poor feeding, seizures or apneic episodes, altered levels of consciousness, or bulging fontanelles. We're looking about dehydration. We worried about it being sunken in, so that it's going to be bulging out. So we're going to do a complete neurological assessment on this kid, right? There's obviously something going on. Retinal exams, monitor for increased ICP. Obviously, they have it if they've got a bulging fontanelle. Stabilize their airway. You're going to have a whole multidisciplinary care team. This is something where CPS will be involved. So you're going to have your case managers and social work involved. A lot of times, you'll have these babies come in, and it's a matter of like the parents couldn't wake them for whatever reason. Baby wasn't waking up, baby was kind of being weird, and they'll bring them in, and then we'll find that they have this type of injury. So it's oftentimes a caregiver. So yeah, but you can see basically, I mean, babies have really heavy heads, right? And that brain gets jostled around and banged around from front to back. And then we have swelling and all kinds of other sad things. There's a lot of writing, it's hard to see. And then just, you don't need to know this, but just know 51% of the time, it's a relative, not necessarily a parent, and 77% of the time, it's an adult. So they know better. But people don't always cope well. Okay. I think this is our last little mini case study. Alright, so what's our priority nursing intervention for this poor baby?
So we got set vitals.
He's breathing at 14 and his heart rate's 100.
That's up it.
We need to up it, yeah. So what's our priority? Our way. What else?
See if there's any stimuli.
Yeah.
Do a GCS.
So, top right area is airway breathing, right? It doesn't say. I hope the paramedics came in bagging this kid. It says airway breathing, prepare for intubation and assisted ventilation. 14 is way too low for a 7-week-old. Set up respirator, circulation, the heart rate's too low. Neurological status, if he's got fixed and dilated pupils, that's not good, right? And then your secondary would be things like looking for any kind of bruising or any kind of other signs of injury. What lab orders do we expect to see? CT, good. Huh?
Labs.
Labs or diagnostics, sorry.
Yeah.
So it says complete blood count, complete metabolic, type and cross, to assess the child's blood type before blood products are given. They may have some sort of a bleed, right?
Just a form
PT and PTT to evaluate for clotting. Possible amylase and lipase for possible identify pancreatic injury. Liver function test for possible liver injury. CT or MRI of the head, abdomen, and extremities. And then ophthalmic exam. We're checking for retinal detachment, right? For baby. So mom was at school, her boyfriend was watching him, and then before she got home he said he just went to sleep, but then when she went to check on him an hour later, he was unresponsive and breathing funny. What subjective and objective information would cause you to call social services? I mean, this whole situation, you're gonna call social services, right? But what are kind of the red flags, I think, is what they're looking for here.
I was asleep and then checked in later.
Yeah. The baby was found unresponsive. That's kind of a weird story. The kid's physical condition. And then, of course, we're gonna talk about any evidence we find in that imaging of trauma or past or present fractures. Sometimes you have babies or kids who come in for something else, and then when they scan them, they find old injuries or varying levels of injuries. It's very hard to break babies' bones. They're very pliable, so it's not common. So sometimes when you have babies come in with those types of injury or like fractures and stuff, it's like, there's more to this story. Yeah, we definitely want to call social services. All right, drowning. So obviously, drowning is respiratory impairment, right? Your lungs can't work when they're full of liquid.
What?
Doesn't work that way. Well, if you're Aquaman, that's a whole nother story. We're talking about basic human anatomy here. But even near drowning, they can either just have, it can be small amounts of water, or they were able to get them in time and resuscitate them. There still can be there can be long. Let me try and spit this out. So if you pull a kid out of the water and you're able to resuscitate them, are they just okay? How come? Yeah. What are the kinds of things are we worried about? Bless you. Yeah, so any kind of hypoxic event, we're worried about brain damage, right? Any amount of water or liquid in the lungs can wash away that surfactant from the alveoli, so you're not having good exchange, oxygen exchange. Pneumonia, like an aspiration pneumonia. Another thing though, even for kids who are near drowning, the coughing can cause laryngeal spasms, which can lead to pulmonary edema. So then, and that can be up to a week after the fact. So there still can be consequences. They don't have to be immediate. So when we think about even near drowning or dry drowning, do you guys know what that means?
It's like after my little brother had a episode because he fell in the pool.
Okay.
And then my mom was afraid of the dry drowning, so because he was having issues during sleep coughing.
Yep.
And so they took him to the hospital, and he still had a little bit of like fluid left in his lungs.
Yeah.
So, but they can die from just that.
You
in their sleep.
absolutely can.
So
So just because they didn't go unconscious, they still probably aspirated water, got it into their lungs, and it can have it doesn't have to be immediate. So dry drowning or secondary, it's not very common, but even a small amount of inhaled water irritates the airway and causes those laryngeal spasms, can cause cough, can cause pulmonary edema. They'll have coughing, chest pain, difficulty breathing, extreme fatigue, and it can be hours or like up to a week after being pulled from the water. So any child, any person really, not just child, any person who has a drowning and near drowning needs to be evaluated. Again, oh, the other thing is what other body system can take a hit besides the lungs? The brain, absolutely, if it's a hypoxic event. There's one other, the kidneys. We mentioned it earlier, the kidneys. So because they have that possible hypoxic event, or just the hemodynamics are off from the event, the kidneys can stop producing urine and won't stop working properly. And that it's an acute thing, it'll come back, but it's something that we have to be mindful of, right? How do we prevent drowning? Watch your kids around water, absolutely.
Don't leave unsupervised with bathing.
Yep. It happens really fast. Yep, don't leave any kind of buckets around. Don't. Make sure you have a gate. Make sure if you have a pool gate, there's nothing that they can push up against it to climb over it. Keep your back doors locked. It's very sad and it's very avoidable. And you guys, I mean, we live in Arizona, a lot of people have pools, right? So you hear it all the time. In the summertime especially, there's near drownings constantly. And it's very, and it can be very, this is another one that's really hard on families because again, it's avoidable. One of the things that can happen though, too, is if they have a drowning or a near drowning because they have that hypoxic event, it can also cause swelling in the brain. So, why are you creeping on us? It can cause swelling so that they might think they're getting better.
Just seeing where you're at.
We're almost done. We're talking about drowning and near drowning. So your nursing assessments, obviously respiratory, right? We already kind of talked about this. We're gonna do a good respiratory assessment, neuro assessment. Watch for those signs of aspiration. And then immediate care, our primary, right? Airway, breathing, circulation, right? Always airway, breathing. Do they need ventilation? Do they need oxygen? And then we're gonna watch for that pulmonary edema, that cough, any signs of like an aspiration pneumonia. Continue to monitor neurologically, and then educate family, right? Water safety, keeping those, like we talked about, keeping those gates and stuff locked up, those pool gates and things. I think last is ingestion. So what do kids do?
Stick everything in their mouth.
Everything in their mouth. So, and this can be kind of scary, especially if they're quick and you don't know that they did it. So this is where it's really important to always keep all medications locked up. Because even if they don't taste good, for some reason they eat things that don't taste good. And you're making sure you're keeping your household cleaners. Like, I don't know why kids drink the things they do or eat the things they do, but things that people don't think about is house plants. Sometimes you can have plants that are toxic to your pets or your kids. So kind of knowing what you have in case the kid decides to start chewing on the leaves again. And then batteries are a really big one because you don't see them do it. And they can start causing severe permanent damage within 2 hours, and as quickly as 2 hours.
Especially the button batteries.
Yeah.
The other, like your AAA or AA, they don't erode like your button batteries do. So I've seen it where we've just let like AAA or AA just kind of work their way through their system and let them pass. But the button batteries, they don't hold up to the gastric acid and digestion, and they will break down and they will cause an issue.
Are those like the circular thin?
The circle,
Yeah.
the circle thin ones, yeah.
Yeah, I guess because they don't have that coating like how a regular battery does, I'm guessing. They're just exposed. So what are your priority assessments for ingestion? Airway.
Make sure there's nothing still in there.
Yeah, so hopefully parents or guardian or whoever they're with will have an idea. Either they'll see remnants of something, so they'll know what they took, the time they took it, because different medications are gonna have different half-lives, right? And then any symptoms, we're gonna do neuro checks, right? How alert are they? Are they having any kind of seizures, lethargy? Did they vomit at all? We're not gonna induce it, but we're going to wanna know if they did. And if they did, what was in it? Was there remnants of pills or anything in it? Monitor your airway, breathing, circulation, neuro assessment. And of course, poison control will be involved, and possibly activated charcoal.
And poison control, they will they follow up to, and they will call at least once, if not multiple times a day, just to see how the kid's doing.
Yeah.
But they will be the ones who kind of dictate the course of treatment and how much they're going to need, right? So when they call, they're gonna ask you for like their assessment data, their lab values, things like that. And that will help kind of navigate what you're gonna do next.
And they usually will follow for like, depending on what it was, but like 24 hours or until like the kid is stable, they'll continue to call and talk to the nurses.
So, what if a baby, like found some drugs somewhere? Would they do they give babies charcoal too?
Mm-hmm. Yep.
Question. Depending on what they swallow, what some of this that the kid pooped out, if they can or not.
Mhm.
Yeah.
Oh yeah, we've allowed like thumbtacks, batteries, like all sorts of things that will move through, because after it leaves the stomach, it's really hard to go in and retrieve it without doing surgery. And so unless it's causing an issue, they will continue to watch it go. They may do like serial x-rays just to kind of see like where it's at, making sure it's continuing to move. But until the kid shows like signs of like it perforating or something like that, they won't necessarily go in and retrieve it. They'll try to like the digestive system works really well at like protecting that thing and moving it through without causing issue most of the time. Yeah. So there's
Somebody went down to swallow a penny.
yeah, coins,
they're-
marbles.
It's just like
All the time.
Yeah. Oh yeah. I mean, Lucas swallowed a marble one time, and they're like, "You can just search through his poop." I was like, "I don't even do that at work. I'm not doing that."
I'm just gonna assume as long as he's pooping, it went through.
I saw
Exactly.
something where a dog swallowed something like a blinky lighty thing.
Oh, yeah,
of some
they-
sort, and it's like coming out in his poop, and his poop was like blinking light.
Yeah.
Yeah.
Or like an AirPod, you know, and you can connect it and play
Ew.
music through it.
Oh my god. Oh goodness. And then this is just a chart of the most common things that kids like to ingest.
I'm gonna be tested on that.
No.
Oh my gosh.
Yes.
I love it.
That's what
Oh, but they had a question, and I think. So a nursing blah, 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 blah. This is across the board, so everything that we've talked about today. Your ABCs right, your vital signs, your neuromonitoring. Pain and anxiety for your patient and your family, right? We talked about a lot of these are gonna cause stress on the family. Family-centered care, being open and honest with your communication, educating them, and that goes back to what we talked about on the first day, right? Involving your family, involving them in the care is gonna help make it easier for all of you. Documentation excellent.
If you didn't document it, it didn't happen.
True.
And then, as we've talked about along the way, these are all gonna be multidisciplinary, right? There's a lot of people gonna be involved in any of these.
I have a question. It's not related to this, but for shaken baby syndrome, is that non-accidental head trauma?
Yes.
Or
Correct.
Yes.
in the
Yes, it's non-accidental, so meaning it happened on purpose, right? So your non-accidental trauma would be like if you were in a motor vehicle accident, right? No, hold on.
That is
No,
accidental
that
trauma.
is accidental. Non-accidental means it happened on purpose.
Yeah.
Sorry,
So abuse.
I'm still working on my coffee. Non-accidental is that it happened on purpose, like abuse, so either the child was beaten, or they were put like in a hot bath, or they were shaken, something like that, that's non-accidental.
So-
Your accidental trauma would be like a motor vehicle accident, or if they were running and they tripped and fell and hit their head, or something like
do
that.
we focus on the entire non-accidental trauma section or just the shaken baby?
Just that, yeah, yeah. So, when we're looking at topics for that chapter, it's just drowning, shaken baby,
Burns.
burns,
Ingestion.
and ingestion are kind of the big ones.
Yeah, burns, ingestion, shaken baby, and drowning.
Yep.
I thought this was actually really cool. I showed it to them and they asked if we could post it. Just because it's a comparison between the acute renal
Oh, yes.
syndromes
Yeah,
to help differentiate between the two of them.
yeah, and there's case studies that do that. Yeah.
So they were interested in that. And then there was a question about the wonderful burn chart.
Yes.
They wanna know what it's gonna look like on the exam. And I'm like, I don't think you're gonna have, if you have to calculate, we're gonna give you the numbers.
Yeah. Yeah, it's
Down.
not, it's not.
You don't have to memorize the burn chart.
No.
I didn't think so.
No.
But it's just like, somebody asked if we would provide it, and I'm like, I don't even think that's gonna be a.
No. When it comes to burns, like the calculation that that you may have to do is like the Parkland formula. So
Yeah.
based off of their weight, how much are they gonna get as far as fluid in the first 8 hours versus and then the rest.
We did that.
Yep.
So we'll be given the burn percentage. Or you don't need it again.
The what?
So-
Doesn't the burn percentage go into it?
You'll have all the numbers.
So like if
Yeah,
you
because
have
your
to
Parkland formula is their weight times their body surface area equals like total
so
percentage.
if we're wanting you to figure out what the, total body surface is, it'll have the numbers, just like how it
you'll
did on
have
that
all
one.
you'll have all the numbers. It's just it's another plug and play. Yeah, just like the BSA was a plug and play. You'll have everything you need.
Where's that?
Your little thing for
These burns. It's right there somewhere. This one. Yeah, so how this one broke down what the different areas were, you'll have that information. Yeah,
Yep, that'll be plug and play. Yep.
okay,
Okay.
we're done.
Okay.
Do I assume use mine or? My thing quit working. I don't know. I was very frustrated. Then it started up again and then. We can get rid of this.
I don't know, I need to look for
I just can't pull a gamma on here. It's so frustrating. Gotta figure that out.
I don't know, I think I'm gonna.
Oh, do you want this?
Yeah, because I was just gonna see.
See if it'll work. It didn't work and then it did and.